the therapies that we have been using in the past is basically immunosuppressant therapies. So that's well and good when our immune system is actually not helping us, like in a Th2 response. But immunosuppressant therapies may actually not be the ideal when our immune system was actually getting a good response to the tumor and we're now suppressing it. So the immune response to cancer is important to harness it, and it's important to understand it. And what I'm going to explain today is two of the immuno-oncology treatments that have recently been published, as I mentioned, since 2011. The checkpoint blockade, which breaks on the inhibition of very specific immune response, and the CAR T cells, which mean chimeric antigen receptor cells. So what is the role of co-stimulation? In general, when a dendritic cell is presenting an antigen, the antigen will actually be identified by the T cell in red through the T cell receptor. Now, this naive T cell will not respond because the CD28, which is the co-stimulatory ligand, that CD28 is hanging. It doesn't actually identify anything. So T cells that only have presentation of antigen with no co-stimulatory signals basically do not respond to the antigen. When the danger signal is perceived by the dendritic cell, they not only present the antigen, but they are becoming activated. And the activation of these dendritic cells will express the co-stimulatory molecules, which in this case is depicted as the B7. So the difference between the top and the bottom is that now you see the dendritic cell in salmon color expressing the purple B7 co-stimulatory factor that will engage with the CD28 from the T cell, and this is what activates the T cell that has been identified specifically by the specific antigen presented via the T cell receptor. And here's our friend, the interleukin-2, which, as you remember, interleukin-2, TNF, and interferon gamma are basically the Th1 responses. So now there's going to be an effector cell that will be able to kill the tumor. Now the story with co-stimulation is very complex. It's not as simple as that. As you can see here, the B7 1 and B7-2 molecules, both of them engage the CD28. So the top of the cartoon here is a presenting cell, and the bottom of the cartoon has the T cell with the red co-stimulatory factors from the T cell. They look very similar, but their action is opposite. So when you have the same antigen presenting cell activated with a B7, either 1 or 2 expressed, they can engage the T cell by either binding the CD28, activating the T cell, and making that T cell kill the tumor, or they can engage this new thing, the CTLA4, which actually inhibits the T cell. So these processes are very important to understand because the difference between the two of them have to do with affinity and avidity of this binding, and they are self-controlling systems for the response of the T cells. I encourage you to read a bit more about this in detail, but the important message here is that the same co-stimulation from the dendritic cell in green can engage either the activation of the B cell or the inhibition of the T cell. A similar thing happens in the periphery. When the PDL1 and the PDL2 are going to engage the PD1 co-stimulatory factor of the T cell, and this is again a regulatory mechanism. In this case, the activated presenting cell will actually start telling the T cell to calm down. So these are all regulatory mechanisms of the immune system in a normal circumstances. So when we have the antigen presenting cell, in the middle it's presenting the antigen, that in this case is in green, and in pink you have the T cell that has a T cell receptor in the middle and it can either be engaged by the B7 through the CD28, in which case the T cell will be activated, or through the CTLA4, in which case this T cell will be inhibited and will not respond to that particular antigen. So a modality of treatment in cancer was using anti-CTLA4 antibodies that would be blocking antibodies but not stimulating. In other words, it's like a chewing gum stuck in your shoe. So basically what this is doing, it's just blocking the CTLA4, but it's not activating it. So when the antigen presenting cell presents now the tumor antigen and it's activated with B7, it only has one other co-stimulatory available ligand on the T cell, which is the CD28, which leads to activation of these T cells. So when you are using CTLA4 antibody, what is happening there is that every tumor antigen is being presented, and it doesn't matter how high amount, how low amount, these particular T cells identifying that antigen are going to be going after it. But the anti-CTLA4 is blocking all the CTLA4s in all the T cells. So we need to watch out, because basically now all the T cells that are presented any sort of antigen by the dendritic cells that are activated will be engaging CD28, will be active. This is a different way of showing what I mentioned to you before. In green is the dendritic cell that is activated. In blue is the T cell. And if you see there, what we are depicting here within the lymph node, within the primary lymphoid organ, what you have in there is the MHC is presenting the antigen, in this case it's a little yellow ball, to the T cell receptor in salmon color. And the B7 is expressed because the dendritic cell in green is activated. What happens in the blue is that this individual is treated with anti-CTLA4 antibody, and so the CTLA4 co-stimulatory ligand is not free to engage with the B7. So the B7 that is expressed in the green cell, which is the antigen presenting cell, can only activate the CD28. Now remember, I mentioned to you about the PD1 and the PDL1. These are working in the peripheral tissue. So the CTLA4 works in the lymph nodes. In the periphery, we have again in blue the T cell, and now we have in orange the cancer cell in the peripheral system. So this T cell is being presented the antigen to the T cell receptor, and again the cell is activated by having PDL1 antibody that normally would bind the PD1, which is inhibitory. So remember, this mechanism is exclusively inhibitory, and it's the way that many cancers can escape the T cell control, because they would be expressing PDL1 and they would be inhibiting the T cells in the periphery. So whereas the CTLA4 inhibition works in the lymph nodes in the central tissue, once it goes to the periphery, these T cells could potentially continue being inhibited by the peripheral effector phase. So the PDL1 or the PD1 inhibitors, these antibodies to either of the two, can block this inhibitory mechanism. And that's how we have what we call the checkpoint blockade. So the checkpoints are these mechanisms of co-stimulatory signals that the T cells have to avoid having a perpetuation of an active disease. So normally there's activation and inhibition. and most importantly, there's an inhibitory mechanism in the periphery. Now, in the situation where we have a cancer growing that has escaped the immune vigilance, we actually do not want to have more inhibition on the T cells. So by using either a blockade of this checkpoint in the lymph node using CTLA4 or in the periphery using an antibody to either PD-1 or PD-L1 is going to help the T cells to be completely uninhibited from the activation and killing the tumors. Furthermore, there's been the idea of combining checkpoint blockers, and it's already been done for the CTLA4 and PD-1 checkpoints, and the results are truly dramatic. So it is very useful to have not only one point of blockade, but using the blockade on the two of them. The possibilities also of using any one of the checkpoint blockades with another therapy, so combination therapies, it's also being pursued in active research, and they could be either an agonist antibody that can activate some of the receptors, or it could also be a kinase inhibitor that can target a particular cancer or an oncogene. So these blockade, checkpoint blockade treatments are not necessarily the end of the story. They have opened a new chapter and a new hope for patients with cancer. Now, if we are blocking the inhibitory mechanisms of the T cells, evidently these individuals are walking with a constant perpetuation of an activation of T cells to any kind of presentation. So they're prone to have autoimmune reactions, inflammatory disorders. They will react to anything dramatically. Of course, if they are reacting to danger, that's good. You know, if they're reacting to infections, those T cells are really primed to act. But if it is another situation, is that they can lead to these autoimmune reactions. Evidently, the risk-benefit of this treatment has to be considered patient by patient, and if the patient has cancer and the cancer needs to be treated, the lookout for potential autoimmune disorders developed is very important in the clinic. Follow the patients and see if they're having any of these manifestations, and then follow them up once the treatment can be discontinued, the treatment for cancer. The next immuno-oncology big area is the CAR T cells, or the chimeric antigen receptor T cells. So I wanted to start with the blockade because there's an association of the systems, and understanding the blockade is a first step to then understanding the CAR T cells, in my opinion. So what you have on the pink on the left is a CD4 T lymphocyte, and then on the right is an antigen presenting cell. So the first thing is that you see there the signal transduction elements or receptors on the T cell membrane, and you see the T cell receptor. The T cell receptor is the one that will specifically identify the antigen being presented by the class II MHC from the antigen presenting cell. But the T cell receptor in the internal domain, the intracellular domain, does not have a signal transduction motif. So that is the reason why when presented by the antigen presenting cell without having any other signal transduction, any other signals for antigen presentation for co-stimulatory signals, then that cell does not respond because the T cell receptor has no way of activating internally. The domains that internally will produce phosphorylation and activation And signal transduction basically is the CD28, the motifs that have the item motif like the CD23, and you have then that expression. So this is the reason why when you see the antigen presentation with a co-stimulatory signal like the B7 that we discussed, it will engage the CD28, and it is this moiety, the one that will activate for a signal transduction inside the cell that makes this a killer cell. And in addition, it will help express the adhesion molecules that attract these T cells to the site where they have to be doing the killing. So the T cell receptor, which is the one that has the specificity for the tumor cell in this case, unfortunately does not have the ability to produce a signal internally and produce the killing. It needs the other co-stimulatory cells. So the idea was to use a tumor-bearing patient, isolate the lymphocytes from this individual that actually will identify the tumor, expand these cells, and then what happens with these cells is that they are transformed. So in the rectangle in the middle, what you are seeing is basically what these chimeric cells are. So the cells from the patient are taken into culture, and their T cell receptors are transformed, they are engineered. What you see here now is a T cell receptor with the VH and the VL loops extracellularly, and now intracellularly we have engineered the item motifs and the CD28 intracellular motifs. So you take the intracellular signal transduction motifs from their respective receptors, and you no longer need a co-stimulatory signal. You only need the T cell receptor engaging with that antigen to produce signal transduction and activation. We got rid of the need to have a co-stimulation. On the other hand, because these are done with the patient, these are very specific for the patient cells that identify the specific tumor antigen. So this particular therapy is a therapy that has shown, and as I mentioned to you, it has already been approved by the FDA to produce tumor regression in these individuals, is very specific to the patients, very much individualized medicine. And what you see here is basically a T cell that no longer is dependent on having the co-stimulation. The success is remarkable, especially for leukemia. There's a risk of cytokine storm, and this has been actually seen in publications. I will explain that in the next slide. But yes, there is a risk of cytokine storm, because what happens now is that these T cells, again, by not needing the co-stimulatory signals and by having the T cell receptor directly active and capable of mounting a response, it could be really out of control. And the other question that happens is, what happens is if the tumor now mutates and loses the particular antigen that was identified by this T cell receptor. Now we have a chimeric antigen receptor T cell in the individual that's no longer useful because the tumor mutated. Do we do the chimeric antigen receptors again with the same individual? Do we try again? What's going to happen when there's variants on the tumor? So there are several different questions, but there's a lot of promise. The first generation of the CAR T cells basically had, as I mentioned to you, the variable region light chain, the variable region heavy chain, VL, VH, from the T cell receptor, and intracellularly they were actually included the CD3 internal signal transduction motif. On a second generation, The biologists said, well, why do we stop there? Why don't we put also one co-stimulation domain, like the CD28, plus the CD3 signal transduction domain? So why don't we put two? And then on a third generation, why don't we put more than two? Why don't we use other co-stimulation domains? The possibilities are really probably not endless, but many, especially as we learn more and more about these T cells and how they work. And this engineering can go on, and we can have T cells that are actually super T cells that will be basically responding to very small loads of antigen with a tremendous internal signal transduction. So in the laboratory, the possibilities are many, and many of them will make it to the market, hopefully. But there are limitations. First, I mentioned the cytokine storm. And in the paper in the New England Journal of Medicine of 2014, the first children that were treated with, they had blood cancer. Basically what they saw is that the cytokine responses were basically interleukin-6. So their recommendation and what they did was to treat them with anti-IL-6. So there is therapy for that. There's a potential for that, and especially when you're treating lethal disease and you know what to expect and how to treat it. But of course, there's a risk of long-term damage. Remember that we're actually introducing an engineered T cell. But that T cell, once we put the genes in there, can reproduce. And it's going to be there. We don't know exactly for how long. Could be there for the life of the individual. So it is very good for a first approach, very potent, and it can deal with the specific antigen, but these T cells have the capability of remaining there as memory cells for forever. So the other thing is that they work very well in blood tumors, but in solid tumors, the problem is that these CAR T cells would need to also get to the tumor. So it is a little bit of a problem to know exactly how can we bring these T cells, these very potent T cells, that now just with a T cell receptor can have internal signal transduction to the tumor site. Evidently this can be worked out, but it's another one of the challenges, and it's a reason why the first ones were in hematological tumors. And so the other problem or challenge is, what if the tumors escape this system by now mutating and losing the antigen that was identified by the chimeric T cells? So the tumor could develop resistance to the CAR T cells. The CAR T cells could be memory cells remaining in the system, but the patient could actually have recurrence of the tumor by the cells that developed the resistance to these T cells. And finally, evidently there are technical and regulatory challenges, because this is personalized medicine to the utmost. It's not only individualized for the patient, but also for the type of antigen the tumor is identifying. And of course, this is very difficult to produce and have it ready for a variety of patients and a variety of tumors. So this is very hopeful for patients with cancer, but it's also a bit challenging to make sure that we can generalize it and have it for many patients, many cancers. So the current work and research that's geared on the CAR T cells is a prospect of being able to have a gene-edited universal CAR T cell. Is that possible? Can we have a human universal T cell that doesn't have to be from the patient and that has this ability of having the T cell receptor activated without needing co-stimulatory signals? So basically, there's a lot of things going on, but as you saw, the checkpoint inhibitors are critical, they're very important. There's a lot of work going on, and CAR T cells are the two elements I wanted to discuss as part of what we call today immuno-oncology, but that probably...
I hope this short summary was useful, and you can see the longer version of the immuno-oncology presentation in my YouTube channel. Thank you very much.